Good afternoon. I'm Dr. Jonathan Silverberg, and I'm an associate professor of dermatology at the George Washington University School of Medicine and Health Sciences. And today I'll be discussing emerging global and U.S. epidemiologic trends in atopic dermatitis. These are my disclosures. None of these should really be relevant to anything we'll be discussing in today's presentation. All right, let's get started. So first big question that comes up is, how common is atopic dermatitis? And here we've had quite a bit of a shakeup and new patterns that have really been established in our understanding of the disease. I'm showing you a study that was published a few years ago. It is an international cross-sectional study of patients taken from web-based internet panels and assessed the prevalence of atopic dermatitis using a composite definition. There is a modification of the United Kingdom Working Party criteria that examines active flexural eczema in the past 12 months, as well as self-reported physician-diagnosed atopic dermatitis. Now, both of these have been shown previously to be valid definitions, but of course they should perform a little bit differently because, some patients have active flexural disease but don't really see a doctor because they know what they have. They've been, had 30 years of atopic derm. Their grandmother told them, and they know they have eczema. On the other hand, some patients may have a historical diagnosis of atopic derm, but haven't been active in the past 6 to 12 months of disease. So each of these performs a little bit differently. When looking at a composite definition for diagnosed atopic dermatitis prevalence, what was found was in the US adult population, approximately 4.9% of adults with atopic dermatitis. Now, when you look at Canada and other countries, some are a little bit higher, some are a little bit lower, but overall really in the similar ballpark, with Italy and Spain having the highest prevalences. I don't expect you to remember all these numbers by heart, but what it really establishes is that atopic dermatitis is really a common disease of adulthood around the world. Even if you look at the individual, UK Working Party or self-report physician diagnosis, it's even a higher prevalence than what you see when you look at the composite definition. And so this number of about 4.9% of the US is, again, diagnosed atopic derm, but the true prevalence of atopic derm is probably even higher than that, even based on this study, as we see here. Now, let's take a little bit of a deeper dive into the United States. And here we now have several different studies that have examined the prevalence of atopic dermatitis in children or in adults. From data from the 2010 National Health Interview Survey, used a fairly non-specific question to assess eczema, dermatitis, red itchy rash, and found a prevalence of about 10.2%. But of course, that's not a very specific question. When that question was combined with the people who also had either asthma or hay fever, the prevalence was about 3.2%. The problem is that may be too rigorous of a definition because we know that so many of our adults with atopic dermatitis don't have active atopic comorbidities. So the true number probably lies somewhere in the middle, maybe around 7% if we were to speculate. Well, when looking at the 2012 National Health Interview Survey that used a more specific question around eczema and asked this question both of caregivers for their children and of self-report for adults, what was found was that the proportion or the prevalence of atopic dermatitis in US adults was 7.2%. This number really looks like the number to beat in terms of being the most accurate number for the US right now, and I'll show you other studies that confirm that. What's fascinating is when we look at the prevalence over the life course, what we see is perhaps not surprising that the prevalence of atopic dermatitis is highest in the earlier years of life. There's this precipitous drop that happens in adolescence, but then it's pretty stable and flat, ranging between 6 and 8%, and again, averaging 7% across the adult population. What these data show is that, yes, atopic dermatitis is more common in children, but it is very common in adults. And we should stop calling this a childhood disease and a disease that burns out by adulthood. And I'll show you more data around that in the next few sections. Now, we have a confirmatory study from the Atopic Dermatitis in America study. This was a US population-based study that sought to understand the burden of atopic dermatitis in the US adult population, using also a web panel sampling approach. And over 2,000 adults that were sampled, an additional oversampling done for specifically to understand those who had atopic derm. And what was found was with a different sampling criteria and a different definition of disease, here using a UK Working Party-like criteria, that the prevalence of atopic dermatitis in adults was 7.3%. Now, it's very, very rare in epidemiology to have studies that are so close to each other. 7.2% from the 2012 National Health Interview Survey, 7.3% for the atopic dermatitis in America study. And we have another study done 2005-2006 from the National Health and Nutrition Examination Study that also used a different sampling approach, different definition, and also came up with a number of about 7%. So I think the best estimate of how commonly atopic dermatitis occurs in the US adult population would be about 7%. Now, even though the proportion, the prevalence of atopic dermatitis, relatively speaking, is lower in adults than kids, because there are so many more adults in the US population than there are children, by the fact that it's just many more years represented, the estimated absolute number of adults with atopic dermatitis in the United States is higher than what we see in children, even though relatively speaking, it's lower than in children. All right, let's move forward. How commonly does atopic dermatitis start in adulthood? Another controversial issue. Classically, we're taught atopic dermatitis starts the disease of childhood. 50% of patients will start by age of 1, 85% of patients will start by age of 5, right? Well, it turns out not so simple. So if you look at those studies that are always cited, 50% by age 1, 85% of age 5, look carefully. Those are all studies looking at children ages 0 to 10, 0 to 11. Well, it's remarkable how if you don't look at a child older than the age of 10, you're never going to find an age of onset greater than the age of 10. So we sought to really understand, what about those studies that actually looked in adolescents and in adults? How commonly does later onset disease occur? So we did a systematic review and a meta-analysis across the literature, identified 25 different studies that reported the prevalence of atopic derm or age of onset for studies that looked beyond the age of 10 years. And 17 studies had sufficient numbers to be pooled together. And we found that a pooled proportion of adult onset atopic dermatitis was 26.1%. Said another way, 1 in 4 adults with atopic dermatitis reported having adult onset disease, and it didn't matter all the sensitivity analyses that we performed, similar numbers. Now here you see the Prisma diagram for the systematic review. And here we see a forest plot for the different proportions of adult onset disease across the different studies. Now you'll see that there are wide ranges between, studies, some being higher than others in terms of the proportion of adult onset disease. However, what you'll note is not a single study here reported a 0 prevalence of adult onset or 0 proportion of adult onset. And in fact, even the lowest studies were close to 10% of the adults in those studies reported adult onset of the disease. And for many of these studies, they did biopsies, they did patch testing, they did longitudinal follow-up going forward, they did retrospective look-backs to see if they had charted, documented childhood disease. Didn't matter, still high rates of adult onset disease. So that 1 in 4 number is really the number to beat and the number to remember in your head. Now, this illustrates just the point that I was mentioning earlier, that if you only focus on younger children, you're going to get spurious conclusions. So this stratifies the proportion of adult onset disease or ages of onset of disease, stratified by how far out into the life course they monitor. And what you'll notice is higher up, those studies that only looked at children or adolescents or young adults, yeah, you do see hot spots where most of those cases seem to be starting earlier in life. But as you move further down and you start looking at studies that followed patients throughout the life course, even into the senior years, what you see is that those hot spots start to really disappear. And you start to get actually patients with common later onset disease, even into the senior years of life. So recognize this is a real phenomenon. It's a tricky phenomenon because you have to differentiate that from the clinical mimics like psoriasis, cutaneous T-cell lymphoma, and contact dermatitis. But after you've done your diligence and worked up for those differential diagnoses, you can actually be comfortable from the epidemiology data that there really is a phenomenon, an entity known as adult onset disease. All right, let's switch gears. Let's talk about how commonly childhood atopic dermatitis persists into adulthood, another area that's really been shook up recently. So if you look at the old literature from textbooks 30, 40 years ago, it tells you, atopic dermatitis is a disease that starts in infancy and burns out by adulthood. Well, clinically, I don't know about you, but I see tons of adults with atopic dermatitis who've had it since childhood and it's been around for 50 years and it's never gone away. So obviously it's not everyone that's burning out by adulthood. How commonly does it persist into adulthood? This was a study that really shook up the field. There's a study that looked at the peer cohort. Now, the peer cohort is a post-marketing pharmacovigilance study that looked at patients who were treated with pimecrolimus, which of course is a second-line non-steroidal agent that's typically used in patients with chronic disease. And they repurposed this data set brilliantly to look at epidemiology of atopic dermatitis longitudinally. And what they found was that very high rates of disease persistence into the adult years. And they used something called latent class analysis to look at different patterns of whatever variables you're throwing in, usually a binary categorical variables. And they found two different broad classes. There was a resolving pattern where there was a remittance, and that was observed in 15%. And there was a persistently active pattern that occurred in 84% of patients. Now, this is very provocative because it suggests that the majority of patients persisted into adulthood. Now, you have to take this with a grain of salt because I think this really opened up a lot of discussion, got a lot of media attention, but it may also overestimate the rates of persistence because we know, and I'll show you in the next study, that this was a study that looked at patients who already had chronically persistent disease going in, which is why they would have been put on a non-steroidal second-line agent. So let me get back to that point in a second. We recognized the potential biases of that study. We said, okay, well, what does the literature actually show us? So we went ahead and we did a systematic review meta-analysis with a very, pretty unique quantitative meta-analytic approach using a time to event analysis, right? A survival type, a Kaplan-Meier plot. And what we found was that across 46 different studies that had eligible data, looking at how many of people who had atopic derm at one time point in longitudinal studies, how many had atopic derm also at a subsequent follow-up period. And we found that by 8 years, 80% of children achieved at least one observed period of disease clearance. When we limited that to prospective studies, it was a little bit lower, about 50% of patients had a period of disease clearance. Now, this suggests that there's high rates of disease persistence, but not universal either. And it's a little bit debatable because you have to know how you define the term persistence here is certainly important. And that is important because one of the things we couldn't do from this kind of quantitative meta-analytic approach is to look at, well, if they had a period of clearance, how often did they recur afterwards? So there may be higher rates long-term of persistence than observed here. But what we were also able to do is to look at some risk factors for persistence, associations of persistence. And we found that older age of onset was one, more severe disease across 3 studies that stratified by severity. And interestingly, and I think notably, patients who already had persistent disease were more likely to have continued persistent disease. So if they came in and at the time only had a year or so of active disease, there's a good chance that they were going to have remittance and clear. But if they already had 10 years of active disease, the chances were they were never going to clear. And that's very important as you're trying to counsel patients and think about who's likely to need lifelong therapy, who's not. Now, this is another study that looked at across a pediatric population of younger children, different sort of trajectories and courses of childhood disease. And they also used latent class analysis to look at different phenotypes temporally. And they found 4 phenotypes. One are those who just didn't have atopic derm, either never or infrequent symptoms, but 3 different subsets of those with atopic derm. The early transient ones, which was 9% of the population studied, and that's shown here in the blue with the triangles. That's what we're classically taught occurs, or I should say, I'm sorry, that's the orange with the diamonds, my apologies. Then you have the early persistent, which is the blue with the triangles. And that's the one that, the dreaded one in a sense, starts early and maybe lifelong, or at least continuing throughout childhood. But then there's also a decent subset with later onset disease, as shown here in this sort of darker blue, bluish green with circles. And what's fascinating is all of these subsets were common. The early transient was most common, but the other subsets were pretty common too. So we have to stop telling patients or educating and writing in the literature that this is a disease that starts early and burns out later on in childhood, because yes, that can happen, but there's many other trajectories that can happen as well. To take it one step further, this is a little bit of an older study, but one that very nicely showed 31 different subsets of trajectories designed a priori based on the age of onset and persistence. And amongst all the ages of onset, persistence into adulthood was the most common phenotype, but it wasn't the only one. And periods of disease clearance for many years were observed in up to 13% of patients. And no differences even in terms of disease severity. So lots of different trajectories that can occur, and we have to be careful not to oversimplify and just say it all starts early and ends early. Now, how commonly does severe disease occur? And here I'm referencing that global study again in adults. And there are a few things you have to recognize. One, severity can be defined in many different constructs. There's the patient-oriented SCORAD that looks at body surface area and lesional severity. There's the patient-oriented eczema measure, which looks at the frequency of symptoms. And then there's just a patient's global assessment of how bad their disease is. And they overall correlate well, but they give you slightly different things. And what we see is that while it varies across all countries, there's some pretty high proportions of moderate to severe disease in the adult population. And that does fluctuate with age too, whereas we get into the older age groups, there tends to be a little bit less severe across all of the different countries that were studied. Now, there's some potential biases here where there may be a self-selection bias for more severe disease because, who's going to complete a whole, 30-minute questionnaire or 20-minute questionnaire around atopic dermatitis? It might be the more severe ones. And it's also, when you're using a web panel sampling approach, there may be some biases towards largely urban cohorts, which may not fully represent the experience of all atopic dermatitis patients. That said, it suggests that adults tend to have more severe disease than what we might even observe with kids. And I'm going to show you that that is exactly the case in the United States. Some of the best data we have if in the US is for children, data from the 2007-2008 National Survey of Children's Health, US web-based, or not web-based, but telephone-based survey household, very well-designed sampling approach, found that 2/3 had mild disease, 26% moderate, 7% severe. And there are some hotspots. It varies by state in terms of the proportion of patients who have moderate to severe disease or severe eczema. And here you're seeing proportion with severe eczema, color-coded, where red indicates those hotspots. And you could appreciate that in the Northeast and in the Midwest, there seems to be the highest sort of clustering of that, still for reasons unknown. And years after we ran the study, I still don't have a great answer as to why. When we look at the adult data from the Atopic Dermatitis in America study, we found that also about 40% of patients with moderate to severe disease. And when you compare the National Survey of Children's Health proportions with the Atopic Dermatitis in America proportions, what you see is that the thickness of that blue bar on bottom, the mild disease, gets thinner with age, suggesting that while the prevalence may decrease with age, as I showed you earlier, the proportion of those who do persist are the ones who have more severe disease. All right, let's talk last about racial and ethnic disparities, an area particularly problematic in the United States, but something that likely happens everywhere around the world, just unfortunately not well studied. There's a ton of data from lots of different studies, but I'm just going to summarize at a high level. You have all the references here if you want to take a look. So one, Black children in the United States had significantly higher prevalence of atopic dermatitis and more nights of sleep impairment compared to white children in the US. Black children had increased persistence of childhood AD, and that's a big reason why they have higher prevalence. We don't think, at least at this point, that they have higher incidence, but when they get the disease, it doesn't go away as much because it's lack of control. Black and Hispanic children had more severe atopic dermatitis, were more likely to report their overall health as being excellent compared to white children. And Black and Hispanic children with atopic derm had lower household income, more likely to be uninsured or underinsured, and reported insufficient time during the patient-physician encounter. Black children and adults with atopic dermatitis were less likely to have an outpatient or ambulatory visit for atopic derm, more likely to have emergency department or urgent care visits for atopic derm, and more likely to be hospitalized for atopic derm. And we know, of course, this is a disaster from a health services perspective. It costs the system much more. It means the patients are not getting well controlled. They're getting poor outcomes, and it's a big issue. And lower income and lack of private insurance do not account for all of the racial and ethnic disparities observed in the atopic dermatitis. It's not just access. So access is a big part of it, but I would argue there's other issues that come up as well. Inadequacies in terms of our ability to assess skin of color, bias potentially that comes up, whether implicit or explicit, and then perhaps even biological differences. But a problem is we have so little known about the underlying mechanisms of disease and underlying course of the disease in diverse patient populations. And this is something we certainly need a lot more research in. And with that, I thank you for your attention, and I'll turn the podium over to our next speaker.